Welcome to this comprehensive lecture on prion diseases, also known as subacute spongiform encephalopathies. These are fascinating and complex neurodegenerative conditions caused by misfolded prion proteins. Over the next hour, we will explore the definition, history, molecular biology, clinical manifestations, diagnostic approaches, and management strategies for these devastating diseases. This lecture is based on current medical literature and clinical guidelines. By the end of this presentation, you will be able to define prion diseases and understand their unique characteristics as transmissible neurodegenerative conditions. You will learn how the abnormal prion protein causes disease through a process of misfolding and aggregation. We will discuss the various clinical presentations from Creutzfeldt-Jakob disease to fatal familial insomnia and how to diagnose these conditions using modern molecular techniques. Finally, we will explore the emerging concept of prion-like diseases in conditions such as Alzheimer's disease and Parkinson's disease. Prion diseases represent a unique class of neurodegenerative disorders. They are transmissible conditions caused by an abnormal form of the prion protein that is extraordinarily resistant to standard sterilization procedures. Unlike conventional infectious agents, prions contain no genetic material, no DNA or RNA. Instead, the disease is transmitted through the propagation of misfolded protein. The pathology is characterized by spongiform changes in the brain, meaning the tissue develops a sponge-like appearance with numerous small vacuoles. These diseases are uniformly fatal once symptoms appear. Prion diseases have several distinctive characteristics that set them apart from other neurodegenerative diseases. First, they are transmissible, meaning infected tissue can spread the disease to other individuals or animals. However, transmission typically requires direct contact with infected nervous system tissue. Second, the pathology is non-inflammatory, which is unusual for a transmissible agent. There is minimal immune response despite the presence of abnormal protein. Third, the hallmark protein, PRPSC, is resistant to protease digestion, which is how we identify it in diagnostic testing. The disease causes progressive neuronal loss and gliosis, leading to the characteristic spongiform appearance. Prion diseases are classified into three main categories based on their etiology. The sporadic forms, which account for approximately 85% of all cases, arise spontaneously without a clear source of infection or genetic predisposition. Familial forms, comprising about 10% of cases, are inherited in an autosomal dominant pattern due to mutations in the prion protein gene. Acquired forms result from exposure to infected tissue, either through ritual practices, contaminated medical equipment, or dietary exposure. Understanding this classification is crucial for determining the likely etiology and prognosis of each case. Sporadic Creutzfeldt-Jakob disease is the most common form of prion disease in humans. It typically affects elderly individuals, usually in their 60s or 70s, with a median survival of approximately 6 months from symptom onset. The classic presentation includes the triad of dementia, myoclonus, and characteristic EEG findings. However, not all patients present with all three features. The disease causes rapid cognitive decline, often accompanied by visual disturbances, cerebellar signs, or pyramidal signs, depending on the brain regions affected. Modern imaging shows distinctive patterns, and the newly available RT-QuIC test in cerebrospinal fluid has revolutionized diagnosis by providing high sensitivity and specificity. Variant Creutzfeldt-Jakob disease represents a tragic consequence of the bovine spongiform encephalopathy epidemic in the United Kingdom. This form of prion disease emerged in the 1990s and is thought to result from consumption of contaminated beef products. Unlike sporadic Creutzfeldt-Jakob disease, which typically affects the elderly, variant disease strikes younger individuals with an average age of onset below 30 years. The clinical presentation differs significantly, with prominent psychiatric symptoms early in the disease course, followed by ataxia and sensory disturbances. the MRI finding of increased signal in the posterior thalamus, known as the pulvinar sign, is highly characteristic. Pathologically, variant disease shows abundant florid plaques, which are PRP immunoreactive structures with a distinctive appearance. Familial Creutzfeldt-Jakob disease accounts for approximately 10% of all prion disease cases and is inherited in an autosomal dominant pattern. This means that individuals carrying a mutation in the PRNP gene have a 50% chance of passing the disease to their offspring. The clinical presentation can be similar to sporadic disease, but the age of onset and disease duration vary depending on the specific mutation present. The polymorphism at codon 129 of the prion protein gene significantly influences the clinical phenotype, with methionine homozygotes typically showing different disease characteristics than valine homozygotes or heterozygotes. Genetic testing and counseling are essential components of care for affected families. Gerstmann-Sträussler-Scheinker syndrome is a familial form of prion disease characterized by a relatively slower progression compared to sporadic Creutzfeldt-Jakob disease. The hallmark clinical feature is prominent cerebellar dysfunction, manifesting as progressive ataxia and dysarthria. Cognitive decline is typically less severe and occurs later in the disease course. The EEG findings characteristic of Creutzfeldt-Jakob disease are often absent in Gerstmann-Sträussler-Scheinker syndrome. Pathologically, the disease is characterized by abundant amyloid plaques in the cerebellum and other brain regions. The disease is caused by mutations in the PRNP gene, and there is significant phenotypic heterogeneity, meaning that different family members with the same mutation may have somewhat different clinical presentations. Fatal familial insomnia is a rare but fascinating form of prion disease characterized by a mutation at codon 178 of the prion protein gene. The defining clinical feature is severe insomnia with complete loss of normal sleep architecture, including both slow wave and rapid eye movement sleep. Patients experience progressive inability to sleep, accompanied by prominent autonomic nervous system dysfunction, including tachycardia, hypothermia, hypertension, and excessive sweating. Endocrine abnormalities and disturbances of circadian rhythm are also prominent. The disease selectively affects specific nuclei of the thalamus, particularly the anterior ventral and mediodorsal nuclei, with minimal spongiform changes. Interestingly, a sporadic form of fatal insomnia with similar clinical and pathological features has also been described, suggesting that spontaneous mutations or other mechanisms can produce this distinctive phenotype. Kuru holds a unique place in medical history as the first recognized prion disease. It was identified in 1957 among the 4 people of the Papua New Guinea highlands by D. Carlton Gaidusek. The disease presented as a progressive cerebellar syndrome characterized by ataxia, dysarthria, and tremor. Kuru was transmitted through the practice of ritual endocannibalism, specifically the consumption of brain tissue from deceased tribe members as part of mourning ceremonies. The disease predominantly affected adult women and children, as men were excluded from participating in this ritual. The incubation period was extraordinarily long, ranging from 4 to over 20 years, which explains why the disease persisted for decades after the ritual practice ceased. The recognition of Kuru as a transmissible disease was groundbreaking and led to the discovery of the prion concept, for which Stanley Prusiner received the Nobel Prize in 1997. Iatrogenic Creutzfeldt-Jakob disease represents transmission of prion disease through medical procedures and products. Several sources of transmission have been documented, including corneal transplants from infected donors, intracerebral electrodes that were inadequately sterilized, and Duramata grafts. Most notably, cadaver-derived growth hormone used to treat growth hormone deficiency in children resulted in numerous cases of Creutzfeldt-Jakob disease, some not appearing until decades after treatment. The clinical presentation of iatrogenic disease differs from sporadic disease, with prominent cerebellar signs, less early dementia and myoclonus, and often atypical or absent EEG abnormalities. The incubation period tends to be longer than sporadic disease, reflecting the route of transmission and the amount of infectious material introduced. The prion protein is the central player in prion disease pathogenesis. The normal cellular form, designated PRPC, is found throughout the body, particularly in the nervous system. It is sensitive to protease digestion and has a predominantly alpha helical structure. The abnormal form, PRPSC, has the same amino acid sequence, but a different three-dimensional conformation with increased beta sheet content. This conformational difference makes PRPSC resistant to protease digestion, which is the basis for its detection in diagnostic testing. The prion protein is encoded by the PRNP gene located on chromosome 20. Interestingly, the normal function of PRPC remains incompletely understood, though it appears to play roles in cell signaling, synaptic function, and possibly neuroprotection. The conversion of PRPC to PRPS is the fundamental event in prion disease pathogenesis. The mechanism of prion disease involves a fascinating process of protein misfolding and aggregation. When PRPSC comes into contact with normal PRPC, it acts as a template, causing the normal protein to misfold into the abnormal conformation. This newly converted PRPSC can then convert more PRPC molecules, creating a self-perpetuating chain reaction. The misfolded proteins aggregate together to form amyloid fibrils, which accumulate in the brain tissue. This accumulation disrupts normal neuronal function and ultimately leads to neuronal death. Importantly, different conformations of PRPSC, known as prion strains, can produce different clinical phenotypes. The CJD agent can be classified into 6 subtypes based on the PRP gene polymorphism at codon 129 and the glycosylation pattern of the protease-resistant protein, and these subtypes correlate with different clinical presentations. The pathogenesis of sporadic prion disease remains one of the great mysteries in neurology. Several mechanisms have been proposed. One hypothesis suggests that spontaneous conformational changes of PRPC in the central nervous system initiate disease. Another possibility is that somatic mutations in the PRNP gene occur in brain tissue, leading to production of misfolded protein. A third possibility, increasingly recognized, is that some cases of apparently sporadic disease may actually represent unrecognized transmission from environmental sources or iatrogenic exposure. The codon 129 polymorphism plays an important role in susceptibility, with methionine homozygotes being more susceptible to sporadic disease than valine homozygotes or heterozygotes. The disease typically affects older individuals, suggesting that age-related accumulation of misfolded protein may be a contributing factor. Familial prion diseases result from mutations in the PRNP gene that encode the prion protein. These mutations lead to structural instability of the protein, making it more prone to spontaneous misfolding and aggregation. The inheritance pattern is autosomal dominant, meaning that one mutated copy of the gene is sufficient to cause disease. However, penetrance may be incomplete, meaning that not all individuals carrying the mutation will develop disease during their lifetime. The disease typically manifests in an age-dependent manner, with most individuals developing symptoms in middle age or later. The codon 129 polymorphism significantly influences the clinical phenotype, so that the same mutation can produce different disease presentations depending on whether the individual is a methionine homozygote, valine homozygote, or heterozygote. Genetic counseling and testing are important for families with known prion disease mutations. Acquired prion diseases result from transmission of the abnormal prion protein from infected tissue to a susceptible individual. The most efficient route of transmission is direct intracerebral inoculation, as demonstrated historically by the transmission of kuru to experimental animals. Peripheral routes of transmission, such as oral ingestion or parenteral injection, require much larger infectious doses and are less efficient. Following exposure, there is typically a long incubation period, ranging from years to decades before symptoms appear. During this incubation period, the prion agent presumably crosses the blood-brain barrier and begins to replicate in the central nervous system. The codon 129 polymorphism plays an important role in susceptibility to acquired disease. Notably, variant Creutzfeldt-Jakob disease from bovine spongiform encephalopathy is almost exclusively seen in individuals who are homozygous for methionine at codon 129, suggesting that this genotype confers particular susceptibility to oral transmission of the bovine prion. The clinical diagnosis of prion disease begins with recognition of the characteristic clinical syndrome. The hallmark is rapidly progressive dementia, typically progressing over weeks to months rather than the years typical of other dementias. Myoclonus, which can be spontaneous or triggered by sensory stimuli such as loud noises or bright lights, is a highly characteristic feature. Visual disturbances are common and can include cortical blindness or visual hallucinations. Cerebellar signs such as ataxia and dysarthria reflect involvement of the cerebellum. Pyramidal and extrapyramidal signs indicate involvement of motor pathways. Behavioral changes and psychiatric symptoms, particularly in variant disease, may be prominent early features. As the disease progresses, patients typically develop an akinetic mutistic state, becoming mute and immobile before ultimately progressing to death. Electroencephalography is an important diagnostic tool in prion disease. The characteristic EEG finding in sporadic Creutzfeldt-Jakob disease is periodic sharp wave complexes, typically occurring at a frequency of 1 to 2 Hz. These periodic or pseudo-periodic sharp waves appear against a slow background rhythm. This pattern is seen in approximately 60 to 80% of sporadic Creutzfeldt-Jakob disease cases, but may be absent early in the disease course. Serial EEGs may be necessary to detect these characteristic changes. Importantly, variant Creutzfeldt-Jakob disease often lacks these characteristic EEG abnormalities, which is one way to distinguish it from sporadic disease. In fatal familial insomnia, polysomnography reveals marked sleep abnormalities with loss of normal sleep architecture. While EEG findings are supportive of the diagnosis, they are not specific for prion disease and must be interpreted in the clinical context. Magnetic resonance imaging has become increasingly important in the diagnosis of prion disease. Diffusion-weighted imaging is the most sensitive sequence, showing restricted diffusion in affected brain regions. The characteristic findings include cortical ribboning, which represents hyperintensity in the cerebral cortex on DWI, and basal ganglia hyperintensity. The pulvinar sign, which is increased signal in the posterior thalamus on T2-weighted images, is highly characteristic of variant Creutzfeldt-Jakob disease. Cerebellar involvement may be seen in some forms of prion disease. T2 and flare sequences may show hyperintensities in affected regions. It is important to note that MRI may be normal early in the disease course, and serial imaging may be necessary to detect characteristic changes. The combination of clinical features, EEG findings, and MRI abnormalities significantly increases the diagnostic confidence. Cerebrospinal fluid analysis has become increasingly valuable in the diagnosis of prion disease. The 1433 protein was historically used as a marker, as it is elevated in the CSF of patients with Creutzfeldt-Jakob disease. However, it is not specific and can be elevated in other conditions. Phosphorylated tau is also elevated in Creutzfeldt-Jakob disease. The most significant advance in recent years has been the development of the real-time quaking-induced conversion assay, or RT-QuIC. This test detects the presence of misfolded prion protein in the cerebrospinal fluid with extraordinary sensitivity and specificity. A positive RT-QuIC test is highly suggestive of prion disease and has revolutionized diagnosis. Protein misfolding cyclic amplification is a similar technique that is currently used primarily in research settings. Standard CSF analysis typically shows elevated protein with normal glucose, and the opening pressure is usually normal. The diagnostic criteria for probable Creutzfeldt-Jakob disease require rapidly progressive dementia plus at least 2 additional clinical features from a specific list. These additional features include myoclonus, visual disturbances, pyramidal or extrapyramidal signs, cerebellar signs, or akinetic mutism. The diagnosis is further supported by characteristic investigations including EEG findings of periodic sharp waves, MRI abnormalities on diffusion weighted or FLAIR imaging, or positive biomarkers in the cerebrospinal fluid such as 14-3 protein or the RT-QuIC assay. These criteria have been refined over time and are regularly updated as new diagnostic tools become available. The combination of clinical features and supportive investigations allows for diagnosis of probable Creutzfeldt-Jakob disease with reasonable confidence even before autopsy confirmation. Definite diagnosis of Creutzfeldt-Jakob disease requires neuropathological confirmation. This typically occurs at autopsy, though brain biopsy can also provide definitive diagnosis. The neuropathological hallmarks include neuronal loss, spongiform changes, and gliosis. Immunohistochemistry can demonstrate the deposition of abnormal prion protein throughout the brain. Electron microscopy can reveal scrapie-associated fibrils, which are characteristic ultrastructural findings. Western blotting can demonstrate the presence of protease-resistant prion protein. Transmission of the disease to experimental animals provides definitive proof of transmissibility, though this is rarely performed in clinical practice. The combination of clinical features, supportive investigations, and neuropathological findings allows for definite diagnosis of prion disease. The rapid progression of cognitive decline in prion disease requires differentiation from other causes of rapidly progressive dementia. While Alzheimer's disease is the most common cause of dementia, it typically progresses over years rather than weeks to months. Vascular dementia, Lewy body dementia, and frontotemporal dementia are other important considerations. Infectious causes such as viral encephalitis, particularly herpes simplex encephalitis, must be excluded. Autoimmune encephalitis, including NMDA receptor encephalitis, is an increasingly recognized cause of rapidly progressive cognitive decline. Metabolic encephalopathies from hepatic or renal failure, toxic encephalopathies from alcohol or drugs, subdural hematoma, and brain tumors must all be considered in the differential diagnosis. The clinical presentation, imaging findings, and CSF analysis help to distinguish prion disease from these other conditions. Currently, there is no curative treatment for prion disease, and management focuses on symptomatic relief and comfort care. Seizures, when they occur, are managed with antiepileptic drugs. Myoclonus can be treated with valproate, clonazepam, or levetiracetam, though the response is often limited. Pain management is important as patients may experience significant discomfort. Nutritional support should be considered, though the decision to place feeding tubes must be individualized based on the patient's wishes and prognosis. Infections should be prevented and treated promptly. Psychological support for patients and families is crucial as the diagnosis of a rapidly fatal neurodegenerative disease carries significant emotional burden. Palliative care principles should be integrated throughout the disease course. Several experimental therapies have been investigated for prion disease, though none have proven definitively effective. Quinacrine, an anti-malarial drug, has been used in some cases based on limited evidence of potential benefit. Pentosan polysulfate, a glycosaminoglycan, has been reported to slow disease progression in some cases. Immunotherapies targeting the misfolded prion protein are under investigation. Anti-prion compounds that might prevent the conversion of normal to misfolded prion protein are in development. Gene therapy approaches and stem cell therapy remain experimental. Several clinical trials are ongoing at various centers around the world. For patients and families considering experimental therapies, it is important to have realistic expectations about the likelihood of benefit and to understand the potential risks. Informed consent and discussion of goals of care are essential. An exciting area of neuroscience research involves the recognition that prion-like mechanisms may underlie other neurodegenerative diseases. In Alzheimer's disease, abnormal amyloid beta and tau proteins aggregate and spread through the brain. In Parkinson's disease, alpha-synuclein misfolds and aggregates. In amyotrophic lateral sclerosis, the protein TDP-43 accumulates in misfolded form. Multiple system atrophy involves alpha-synuclein pathology. Frontotemporal dementia is associated with tau and TDP-43 aggregation. Huntington disease involves aggregation of the huntingtin protein. The common mechanism in all these diseases appears to be that misfolded proteins can convert normal proteins to the misfolded conformation, leading to a self-propagating chain reaction similar to that seen in prion disease. This prion-like mechanism may explain the progressive nature of these diseases and could open new therapeutic avenues. Recent research has demonstrated that prion-like pathology can be transmitted between individuals, at least in experimental settings. Multiple system atrophy has been transmitted to transgenic mice expressing mutant alpha-synuclein. Amyloid beta and tau pathology, as well as cerebral amyloid angiopathy, have been found in recipients of cadaver-derived growth hormone who subsequently developed Creutzfeldt-Jakob disease. This suggests that misfolded proteins associated with Alzheimer's disease may have been transmitted through the contaminated growth hormone preparation. There is also evidence that misfolded proteins associated with one disease can promote the spreading of misfolded proteins associated with another disease, a phenomenon known as cross-seeding. These findings have important implications for medical procedures and transplantation, highlighting the need for careful sterilization protocols and screening of donor tissues. The potential for environmental transmission of prion-like pathology remains an area of active research. Prion diseases are rare conditions, with sporadic Creutzfeldt-Jakob disease occurring at a rate of approximately 1 to 2 cases per million people per year worldwide. Familial forms account for about 10% of all prion disease cases. Variant Creutzfeldt-Jakob disease peaked in the 1990s and early 2000s, but is now rare, reflecting the decline in bovine spongiform encephalopathy and changes in meat processing practices. Kuru is now eradicated, having disappeared as the practice of ritual endocannibalism ceased. There is geographic variation in the incidence of prion disease, with some regions showing higher rates than others. Sporadic Creutzfeldt-Jakob disease typically affects individuals in their 60s and 70s, with incidence increasing with age. There is no gender predilection. Occupational risk has been suggested for healthcare workers and veterinarians, though the actual risk appears to be very low with appropriate precautions. Because prions are extraordinarily resistant to standard sterilization procedures, special decontamination measures are necessary. Standard autoclaving at 121 C for 15 to 30 minutes is not sufficient to inactivate prions. Effective decontamination requires autoclaving at 132 degrees for 4.5 hours or treatment with sodium hypochlorite or sodium hydroxide. Proper handling of infected tissue is essential to prevent transmission. Blood-borne precautions are recommended, though the risk of transmission through blood is thought to be very low. Organ donation screening is important to prevent iatrogenic transmission. The occupational risk for healthcare workers and laboratory personnel is very low when appropriate precautions are taken. Nonetheless, awareness of the special properties of prions and adherence to recommended infection control measures are important. Genetic testing of the PRNP gene can identify mutations associated with familial prion disease. Testing also determines the codon 129 polymorphism, which influences disease phenotype and age of onset. Predictive genetic testing can be offered to at-risk family members to determine whether they carry the disease-causing mutation. Genetic counseling is essential both before testing to discuss the implications and limitations of testing, and after testing to help individuals understand their results and plan for the future. The implications for family planning should be discussed, including the 50% risk of passing the mutation to offspring. It is important to understand that penetrance may be incomplete and that age of onset can vary. even among family members carrying the same mutation. The psychological impact of genetic testing can be significant, and support groups and other resources are available to help families cope with the diagnosis. This case illustrates the typical presentation of Sporadic Creutzfeldt-Jakob disease. A 68-year-old woman presented with a 3-month history of cognitive decline that rapidly progressed from mild forgetfulness to severe dementia. She developed myoclonus and visual disturbances. Electroencephalography showed the characteristic periodic sharp waves. Magnetic resonance imaging with diffusion-weighted imaging showed cortical ribboning and basal ganglia hyperintensity. Cerebrospinal fluid analysis with the RT-QuIC assay was positive, supporting the diagnosis of prion disease. She was diagnosed with probable sporadic Creutzfeldt-Jakob disease. Despite supportive care, she continued to decline and died 6 months after symptom onset. Autopsy confirmed the diagnosis of prion disease with characteristic neuropathological findings. This case illustrates the presentation of variant Creutzfeldt-Jakob disease. A 28-year-old man presented with psychiatric symptoms including depression, anxiety, and behavioral changes. Over several months, he developed progressive ataxia and sensory disturbances. Magnetic resonance imaging showed the characteristic pulvinar sign with increased signal in the posterior thalamus on TU-weighted images. Electroencephalography did not show the periodic sharp waves typical of sporadic Creutzfeldt-Jakob disease. Cerebrospinal fluid analysis with the RT-QuIC assay was positive. He was diagnosed with variant Creutzfeldt-Jakob disease. Genetic testing revealed that he was homozygous for methionine at codon 129, which is associated with susceptibility to variant disease. His exposure to bovine spongiform encephalopathy was likely through consumption of contaminated beef products. This case illustrates the presentation of fatal familial insomnia. A 52-year-old man with a family history of early onset dementia presented with severe insomnia and marked sleep disturbance. He developed prominent autonomic symptoms, including tachycardia, hyperthermia, and hypertension. Polysomnography revealed loss of normal sleep architecture with markedly reduced slow wave and rapid eye movement sleep. Magnetic resonance imaging showed selective involvement of the thalamus, particularly the anterior ventral and mediodorsal nuclei. Genetic testing revealed a mutation at codon 178 of the PRNP gene with methionine at codon 129, confirming the diagnosis of familial fatal insomnia. He experienced progressive autonomic dysfunction and cognitive decline and died within 18 months of symptom onset. The prognosis of Prion disease is generally poor, with rapid progression and high mortality. Sporadic Creutzfeldt-Jakob disease has a median survival of approximately 6 months from symptom onset, though some patients survive longer. Variant Creutzfeldt-Jakob disease has a somewhat longer median survival of 12 to 14 months. Familial Creutzfeldt-Jakob disease has variable survival depending on the specific mutation present. Gerstmann-Sträussler-Scheinker syndrome typically has a slower progression, with survival ranging from 2 to 10 years. Fatal familial insomnia typically results in death within 6 to 24 months of symptom onset. Kuru typically cause death within 1 year of symptom onset. Several factors influence survival, including age at onset, genetic factors including the codon 129 polymorphism and the disease subtype. Rare long-term survivors have been reported, but these are exceptional cases. Current research in prion disease is focused on several promising directions. The development of disease-modifying therapies is a major goal, with several approaches under investigation. Immunotherapy targeting the misfolded prion protein may help to clear accumulated PRPSC or prevent its formation. Anti-prion compounds that prevent the conversion of normal to misfolded prion protein are in development. Gene therapy and RNA interference approaches may offer ways to reduce prion protein expression or prevent its misfolding. Improved biomarkers for early diagnosis are being developed, which could allow for earlier intervention. A better understanding of prion strain diversity and how different strains produce different clinical phenotypes is ongoing. The recognition of prion-like mechanisms in other neurodegenerative diseases is opening new avenues for research. International collaboration and clinical trial networks are facilitating research and improving the chances of developing effective treatments. Prion diseases have significant public health implications. Many countries have established surveillance systems to monitor the incidence of prion disease and detect any unusual clusters or outbreaks. Reporting requirements ensure that cases are documented and tracked. Blood and organ donation screening helps to prevent iatrogenic transmission. Occupational health and safety measures protect healthcare workers and laboratory personnel. Environmental contamination concerns, particularly related to bovine spongiform encephalopathy, have led to changes in agricultural practices and meat processing. Public education about prion diseases helps to raise awareness and reduce unnecessary fear. Coordination with veterinary and agricultural sectors is important for monitoring animal prion diseases and preventing transmission to humans. International guidelines for prion disease management have been developed to ensure consistent and appropriate care. Prion disease raises several ethical and legal issues that must be carefully considered. Informed consent and full disclosure of the diagnosis are essential. Genetic testing raises privacy concerns, and the results must be handled with care. Family members at risk of inherited disease must be notified and offered genetic counseling. Occupational exposure and worker protection are important considerations for healthcare workers and laboratory personnel. Decisions regarding organ and tissue donation must be made carefully with consideration of the risk of transmission. End-of-life care should be guided by the patient's wishes and values, documented in advance directives when possible. Autopsy and neuropathological examination can confirm the diagnosis and provide valuable information for research and family counseling. Liability and insurance issues may arise in cases of iatrogenic transmission. Patients and families affected by prion disease have access to several resources and support services. Prion disease support organizations provide information, advocacy, and support. Online resources and educational materials help patients and families understand the disease. Information about clinical trials is available through various registries and research centers. Genetic counseling services are available for families with inherited prion disease. Palliative care and hospice services can help to manage symptoms and provide comfort care. Mental health support and counseling can help patients and families cope with the emotional impact of the disease. Support groups for families provide opportunities to connect with others facing similar challenges. International networks and collaborations facilitate research and the sharing of information and best practices. In summary, prion diseases represent a unique class of rapidly progressive, fatal neurodegenerative conditions caused by misfolded prion protein. They occur in three forms: sporadic, familial, and acquired. The diagnosis is based on the combination of clinical features, neuroimaging findings, electroencephalographic abnormalities, and cerebrospinal fluid biomarkers. The recent development of the RT-QuIC test has revolutionized diagnosis by providing a highly sensitive and specific test for misfolded prion protein. Currently, there is no curative treatment, and management focuses on symptomatic relief and palliative care. The recognition that prion-like mechanisms may underlie other neurodegenerative diseases such as Alzheimer's and Parkinson's disease is opening new avenues for research. Ongoing research efforts offer hope for the development of disease-modifying therapies in the future. Awareness and recognition of prion disease are crucial for early diagnosis and appropriate management of patients and families affected by these devastating conditions. Sei unfokus. Thank you for your attention to this comprehensive lecture on prion diseases. I welcome your questions and look forward to discussing any aspects of prion disease that you would like to explore further. We can discuss specific clinical cases, clarify complex concepts, and share clinical experiences. This is an opportunity for networking and learning from each other's experiences and perspectives. For those interested in further reading on prion diseases, I recommend the references listed on this slide. These include seminal papers on prion disease pathogenesis, epidemiology, and diagnosis. Additional resources, including review articles and clinical guidelines, are available upon request. I encourage you to continue learning about prion diseases and to stay updated on new developments in this rapidly evolving field. Thank you for your attention to this comprehensive lecture on prion diseases. I welcome your questions and feedback. I would like to acknowledge the many colleagues and researchers who have contributed to our understanding of prion diseases over the years. This lecture is dedicated to the patients and families affected by these devastating conditions. Please feel free to contact me if you have any questions or would like to discuss prion diseases further.